First of all, I don't have any conflict of interest. Prostate cancer MRI. I would like to give an introduction, and after the introduction, the question is, what's the role of artificial intelligence? I will show that from a radiology perspective, economy perspective, and a healthcare perspective. And then I will end up the presentation on a few remarks on artificial intelligence in screening, how that may help. This is a message which should everybody know. You can test your PSA, but do an MRI the next day. In the past, we have been seeing a lot of overdiagnosis. You know what PSA means in English? Prostate-specific anxiety. Because if your PSA is elevated, you feel terrible as a man. I may have cancer. Well, you know that in 2 out of 3 it's benign prostatic hyperplasia or prostatitis, but I can be one of those 3. Okay, so there was a lot of negative information, PR, on PSA in the past 15 years due to overdiagnosis, and due to overdiagnosis. But that changed. That changed due to multiparametric MRI. What does it mean? It means that we are looking now specifically for MRI to detect tumor. We have the T2 weighted technique, which shows anatomic structures. Also, we have another technique, which is called diffusion-weighted imaging, looking at the velocity of water, which shows cell density. And tumors have a higher cell density. So tumors are black on the ADC and bright on the B15, 14, or 2000 image. And we have vascularity. Vascularity shows the tumor, new forming of vessels. The combination of the 3 leads to the diagnosis, a PIRAT score, and that leads to a targeted MR-guided biopsy. This information, due to level of 1A evidence, resulted in the change of guidelines of the EAU and the AUA, and it's clearly being stated that you should perform an MRI before any prostate biopsy in men with a suspected organ-confined disease. Period. So, dear gentlemen, if any urologist wants to stick in a needle without an MRI, according to these guidelines, he can be sued, talking about legal issues. No, I'm just kidding, but it is not done. Oops, go back. This reduces the number of biopsies by 50%. It reduces the diagnosis of the ISIP, the insignificant cancer, by also more than 50%. And it has at least a similar detection of the bad tumors. Good information. What about the DRA of the urologist? I always say, the finger of the urologist doesn't have eyes, but we have MRIs. This is the new diagnostic pathway. Coming from the start, pre-imaging to do the referral for an investigation, the acquisition, interpretation, reading of the report, and the management. There are, however, a few challenges. First of all, the volume. Second of all, we have the negative predictive value. The negative predictive value is high. It is up to 96%. So that's good news. However, the bad news is that with MRI, we have a poor positive predictive value. As you can see, the positive predictive value is 50%. So if you have a positive MRI in 50%, you're right that it is a significant cancer. But in 50%, it's not. Still, it's better than not doing an MRI. Also, what you see is that the variability among the investigators And my colleague, the pathologist, already told a bit about the observer variability is not good for the positive predictive value. This means that if you want to rule in prostate cancer, this is poor. You are doing unnecessary biopsies. And in the screening situation, this is not what you want. In screening, you do not want to harm the patient by too many biopsies. So a low positive predictive value is something which you will not want to have. So we want to increase that. And I will come to that a little later. What about the interreader variability in the pirates? You see that the interreader variability is not bad, the overall interreader variability and accuracy, but it could be better. Now, what about PIRAT 3 lesions? That is the I do not know lesion, and I don't want to have that diagnosis. This is a very interesting study. The study published in the New England Journal of Medicine, precision trial, and you see that if you have the central read, the experts, the PIRATs 3, the I do not know diagnosis is 6%. However, if you include also the non-expert, it's 21%. So that means that expertise matters. The increased use of MRI. This means that the workload is increasing, the quality goes down. Because now MRI is in the guidelines, 1 out of 250 men need yearly an MRI. And that's an enormous burden of the MR capacity. High workload means hurry, 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 hurry. And I must warn you, this is not good for quality. I thought we were a nice country. We have a widespread availability of prostate MR imaging. We have a nice adherence to the PIRATs guidelines. We made them a bit ourselves, so it's good. But if you comply to the technical specifications of the PIRATs 2.1 guidelines, it is not sufficient to guarantee optimal image quality. Because you also have something which is called a patient. Patient motion, patient individual factors may completely screw up the examination. And we did a survey in my country, and to my surprise, 30% of the MRs in my country were of insufficient quality. Now what you want to do is hurry, 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 no contrast, good. 70% of the centers in my country did not use contrast. Is that good? Well, you see that in those centers, even half of all the MRIs were of insufficient quality. And I would really like to know, actually, because in the UK this is about the same, what would be the quality in Norway? Of course it will be better. In Sweden it will be even less better. I'm in Norway, I should be very careful. It's very sensitive, I know, but test your quality, because now we have PyQual version 2, which is an objective means in testing quality. We have it recently, just a few weeks old. And if you use it, you'll be surprised whether your quality is good or bad. Now the question is AI the solution? Well, of course, yes, AI is the solution, otherwise I would not be here. No, I'm just fooling. Will it replace me? Or will it have me a more ergonomic way of doing my reading like the pathologist? Is it my enemy? Is it my friend? It's my grandson. He recognizes me, not by AI, I can assure you. And I'm in between two urologists, you see? They're a little bit taller, but that's just made by artificial intelligence. Okay, the diagnostic pathway. I'll talk about acquisition, I'll talk about interpretation, talk about report. Let's start with acquisition. Can we do something with acquisition, the making of MR images with AI? Yes, we can. This is a sequence, a multi-parametric MRI. That is the time you use for the acquisition of the images, it is almost 16 minutes. And this is if you use AI. You can see it decreases imaging time from 16 to 8 minutes. Because it fills in some information that you do not acquire. Don't ask me how it's done. It's just like the black box the pathologist presented earlier, but it works. Now, I will come to that later. So in acquisition, it's good. And in the future, we will be able to test the quality. I hope that in 5 years, the machine will say to the technician, quality is bad, so repeat, and the patient will not be able to leave the MR machine until the quality is good, with the risk that he should be there the entire day. But lunch is provided. Okay, now what can we do with AI? First of all, we started with the separation of two zones, the peripheral zone, the bright zone, and the central zone, and the transition zone, so the central part and the peripheral part. And that is important because we want to calculate the volume, and we want to correlate that with PSA. Oops, hey, I'm skipping a bit. We have then the lesion detection and localization. That is the detection of this red lesion over here. It detects a lesion, just tells me there's something going on, that doesn't really yet what it is. The next step is that it is going to classify it, give a level of suspicion to a certain region. So in this patient, you can see that the level of suspicion is 56%. So that means that there is a little bit elevated risk of prostate cancer. So that's what the computer tells us. Then you have, of course, the false alarm reduction. We need also not to have a low PPV, positive predictive value, but it needs to increase. We don't want to have too much overcalls. If everything in the prostate is called by AI a lesion, then you have to exclude a lesion. That you want to have a low number of false positives. So that was the next step. And finally, you need to produce a heat map that is needed to tell the urologist with his fusion technique where he should stick in his needle. It is telling the radiation oncologist where he has to put most of his radiotherapy beam. So, contouring. It is an integral thing of a radiology report. It's not only that we tell there and there is a lesion, but we also need to contour. And AI can do that. Help us. Now, in 2012, you see, this was the beginning of CAD, computer-aided diagnosis, and you can see that the radiologist was still a little bit superior, but the false positives were still very high. You need to exclude 10 false positives before finding one true positive. And that is, of course, the positive predictive value of only 10% is not good. 2012. In 2023, you can see that the false positive rate is a lot better. So we are getting there. So what actually happened is that we called with AI less lesions false positive. And this is a nice publication. Here you have the PROMISE trial of the UK. You have an MR First trial, the publication of our center. So those were the papers that changed the guidelines. And if you now look that in comparison to computer-aided diagnosis, the green curve, you can see that the MR First here was at the green curve. The expert study in our center was a little bit above, but you see that they are getting there. And if you look at the sensitivity, you can see that they're about equal, but that the yield of AI will be a better specificity, a better positive predictive value. So this is still in an investigational environment. AI, as you saw from the previous speaker, also in radiology is false positive. A nodule, a BPH nodule, can be falsely positive. You can have within an area of prostatitis, You can miss tiny tumors. And finally, you can also miss very small cancers with AI. But radiologists may also miss them. So it's not perfect yet. Okay. This lesion was called a PIRADS 4 by a radiologist. It's on the anatomical image. It's a focal lesion. It's over here on the coronal image. It is white and dark on the diffusion, which is clearly a lesion which is suspicious to be a prostate cancer. PIRADS 4. A lesion that was not found was a lesion at the bottom of the apex of the prostate, near, you can see here the prostate, the bladder, and you can see here the external sphincter, near the external sphincter, at the orange arrow. A radiologist didn't call it. Okay. What about the AI? With AI, both the lesion that was called PIRADS 4 as well as the other lesion were suspicious. So if you go back to the image where the AI said at the bottom of the prostate there's another lesion, in retrospect he is or she is, I'm not sure, or it is right. I think it's gender neutral. Other lesions like this one here, over there, it is a lesion which is called positive by AI, but actually it was a little bit positive. It was only 44% positive. If you ask a radiologist, what about this lesion, black and white, he said, well, this is 100%. So there was a classification issue, an undergrading. Still, we're not getting there. This is the most important study. You can see it's a global study with 81 radiologists and 62 radiologists did the reading. Okay. So you can see the expertise of the radiologists. Most of the radiologists were considered to be an expert. So it was an expert study. This is the paper in Lancet Oncology. How did it work? This is how the radiologist works. He had to look at an MRI and then he had to give a diagnosis. And after washout and randomization, he had to do it with AI and make a diagnosis. Now, this is a very unnormal environment. First of all, it's not the machine the radiologist was working with. It's not his own machine. It was a, external database. And I need to know the data from my own machine because certain values, certain quantification is important, and the radiologist missed that quantification. Second, of course, it's a monitor. It's a laptop-like monitor, which is not like the PAC station of a radiologist. So the environment is not optimal. Nonetheless, let's see. Oops. Yep, I think it will work now. You see that on average, the AI system demonstrated a statistically superior ROC curve. That means the higher it goes to this area, the better it is. And the green curve is of AI. And the 62 radiologists on average were not as good. So, very good. However, if you included this into a multidisciplinary environment with all the patient data, you see that they were equal and the radiology performed slightly better. So this was a scientific environment. And most importantly, recently a study appeared from my colleagues from Washington, from NIH. And this is because prospective studies in the real clinical environment are missing yet. There were 200 MRIs from 100 centers, all kind of machines, 1.5, 3 Tesla, various vendors. And they were read by AI. And then there was also the in-house scanning done on the same patient. So they repeated the MRI in the Washington Center of Excellence. And then the AI read those in-house data. Most importantly, it is important where an AI algorithm is developed. And the AI they used was developed in their own center. Now, non-surprisingly, this is a graphic which shows in blue the in-house and in red the external MRI. First of all, you can see that the diagnostic quality for T2 externally was not as good. The same was true for diffusion-weighted imaging. You can see that the sensitivity of the AI system of the in-house system was better. So it was not as good if you have the real-world data. That is same for the sensitivity of cancer and lesion detection and significant lesion detection and also the Gleason grade 3 detection. So the message is that if you use an AI system, it is important what data set you're testing it on. And in the real-world data, it performed not as good as in the scientific studies. The same is being shown by the ROC curves. You can see that the in-house systems for overall lesion detection, cancer detection, clinically significant cancer detection was better as compared in the external system, the external data set. An example, this was a true positive lesion, clear. And here you see a lesion that was missed for some reason, and this lesion was false positive. So this was actually prostatitis. Clinically significant cancer was detected in the in-house system. So that is what you see in studies in 88%, and in the external data set it's significantly less. So that's the warning. What about the report? Reporting is costing a lot of time. If I report a prostate MRI, I look at the images and within, say, 2 minutes, I got a diagnosis. This is an expert AI system here in between those two ears, and brrr, there's a diagnosis. But then I have to write it down in words. English or Dutch or Norwegian, doesn't matter, and that is costing time. I may have to make a comprehensive report that the urologist is understanding. So he knows to know what is there. That is costing time. Also, I have to contour the lesion, so show where it is. This is about, say, 8 minutes to 10 minutes of the time of my reporting, and then it takes 15 minutes for me to report an MRI. So 2 minutes in looking, and the rest is, well, could be replaced. So I think the big gain is in helping the report. Nonetheless, there are only a few systems that are really helping at that moment. So how much will it gain in time? How much faster will I be? Well, this is the only publication, and I can tell you what came out was not really significant. So we are not there yet. The gain in time can still be a lot improved. The average reading time reduced only by 22%. It's a beginning, but okay. Now, what about the evidence? What evidence is there for the environment when we have the systems there? We have, this is the pyramid of level of evidence of Freiberg and Thornbury. You can look at, you can look at from a technical efficacy, diagnostic efficacy, and then finally you go to society. So you want to be at the peak of this pyramid, which is the highest level of evidence and the highest gain you can have by any new technology. So these are all the things you can do. And now the question is, where are we? There's a nice website where you can test in a health AI register for radiology the level of evidence for the various tools. And I just printed out in September 2024 this table, and you can show all the CE-approved commercially available systems. And you can see this is class 1 or class 2B. 2B is the highest. And you can see that only 1, 2, and 3 of them are approved in the United States. It's a lot more difficult. And you can see what they can do. They can segment, they can calculate the volume, they can show where the lesions are, they can make a scoring report, not perfect yet, and they can make a report template. If you now zoom in that, you can see that there are 2 systems which have a high evidence level. The highest is this one, and also there is another one coming up. But this may change any month. I would like to show you how now are we working with AI. So this is what we do. We are reading the multiparametric MRI, the diffusion, the T2, the coronal T2, axial T2, and the dynamic contrast. And we make our own diagnosis. And we calculate the PSA density. That means how much is the prostate producing in respect to its volume. When it's above 0.15, there's a higher risk. And now the system is telling me, do you want to show me prostate lesions? Okay, go ahead. So this is the first lesion. We give it a score of 5, so we think this is a pilot 5. And you can see here, score pilot 5, the location, an automatic contouring. The only thing you now have to do is to have a look. Do I agree? Well, anatomy shows a lesion. It's black and white. The answer is yes, I agree. So you approve. It automatically is being drawn into the scheme, and you are there. Now you have the things finished, the score of pirates and the location, and that's number 1. Now there's another lesion. There's a lesion over here, also being scored, and it shows a pirates 4. Then you very closely look and say, well, this is a black and white lesion, but if I closely look to the location, I see that it is in the transition zone. There you may see lesions that are black and white. So this is a BPH nodule, and you decline the lesion, and you can just say decline, and it will be removed from the list. And you only then end up with 1 lesion, pirates 5. AI supported. But just as the pathologist said, it is AI assisted. So you make your diagnosis first yourself, and then you ask as a double read the AI. Now the final is the healthcare perspective. We do have a shortage of technicians, of radiologists, of urologists. The only where we don't have shortage is patients. We have increasing costs, and we have burnout of specialists. You see that among the specialists, we're pretty bad. Radiology, let me see, pathology, where's pathology? You see? They are implementing AI already since quite some time. The intended use of systems, you can see that there is a CE labeling. That's also important. Which systems can we use in healthcare perspective? And they cost money, so you have to invest money first. And what you're looking for is a CE class 2B or 2 FDA. And then, of course, already the previous speaker mentioned it, it is also the legal aspect which is important. Who is going to be responsible? And what's the role of experience? What are the challenges? The challenges are volume. Well, the volume, we really can't say that AI is reducing this at this moment. Time-intensive task, it is about equal, not yet better. For the diagnostic accuracy, yes, there is a slight gain to be seen, but not in a prospective study, not in a prospective situation. Then in healthcare in general, it still needs to be evaluated. So we have a low number of peer-reviewed papers from the CE certified tools, and the diagnostic efficacy level is 2 or at the most 3. So, are the current solutions really helpful? That's a question still that needs to be answered. Let's now zoom in just a few minutes on screening. What are the needs for screening in MRI? First of all, you need to have top quality. Like mammography, you need to have certified radiologists. And we're going to have them. So, high quality, high expertise. No one. I think AI can help to acquire the data, to have better MR images. In mammography, there is quite a program in improving the quality of the mammograms. So with prostate, we'll have the same, and AI will be helpful. AI will help as an assistant double reader, and AI can help also, as the previous speaker showed with pathology, it can help as a training and also for a self-learning. It can store your own data and can present your own data when you don't want it or when you want it. So you will be faced with your own quality. High numbers, we need to speed up. We need to go as fast as possible. But how are we going to do that? Well, a few tricks. AI can help in the acquisition. You can use non-contrast MRI, that's for screening, very good. You can do only the axial plane, skip 2 other planes, and you can use AI, as I showed, for faster reporting. Well, this is an image which is of a nice quality, but this is of a better quality. And this was only in a 3.5 minute screening protocol. Screening protocol, the manogram takes only 3.5 minutes. That is due to AI. So you skip this image, you skip that image, you skip that image, you use AI, and you end up with an acquisition time of no more than 4 minutes, less than 4 minutes even. This is biparametric and axial MRI. This is the manogram. This is how the images will look like. In black and white, it's the anatomy. In orange, it's the diffusion. It's overlay. You only have to look at one data set of images. And AI is perfect in quantifying all this data. So, this is the manogram for the future. Faster reporting, yes. What we will see is that with screening, the prevalence of cancer is lower. That means we have more benign abnormalities, BPH, prostatitis. You also can see that if you are looking at the recommended biopsy rate, it's going down. So there are less significant, probably significant cancers. So we have an enormous amount of normal things, which we need to report as normal. And with that, AI can help. AI can make a prefetched report, a pre-assigned report for BPH and prostatitis. So it is, look at the images, yes, I agree, then you say click, I approve, and go. That's it. So 2 minutes of looking yourself, 2 seconds of approving. Well, rule in and rule out, that is important. It is a rule out in screening is more important than rule in. You don't want to have false positives. You don't want to have too many biopsies. So you are sacrificing sensitivity to gain specificity. You are, well, I think we can miss a few tumors, but we don't want to stick in too many needles. If we would not have done screening, if we wouldn't have done it, we wouldn't have found them anyhow. So, low FP, false positives, and high specificity reading. You should use non-contrast for that. That's good, because you're less sensitive. You should only call the pirates 4 and 5 positive, so forget about the 3s. If I do not know, it's negative. And you can have the higher specificity, as you've seen, with AI as a second reader. It may be really helping you and may sometimes overrule you. So this is good. Now let's look at the effect of I'm almost finished, at the false positive reads. So you have the unaided radiologist, that is the red one. You have the radiologist with AI, the AI standalone in green, and the expert consensus. Now let's look, the unaided radiologist is looking at images, and at a certain sensitivity, 90%, you have a false positive rate of 40%. So your positive predictive value is 60%. Now, if you use AI or a radiologist with AI, you can see that with the same sensitivity, the false positive rate is going up. The cases that you call incorrect, the false positive rate is going down. So the true positive, the positive predictive value is going up. So it improves, your specificity improves. That's the message which you can also see here. These are the experts readers with a very high sensitivity and negative predictive value. However, specificity is not good. And now look what AI is doing. AI has a fairly good sensitivity, but a very good specificity. And this is what we need for screening. So, AI will be helpful in screening. We are not there yet. There's still some barriers which we have to take. We see, nonetheless, promising results. But we need prospective data, prospective screening studies, not only screening studies to prove that screening is valid, which I think already many studies have shown. So why should we repeat it in Norway? Why should we repeat it in the Netherlands? Whereas in Sweden they already have shown that screening with PSA or Stockholm test, followed by MRI, is the right way to go. Okay? Nonetheless, our governments require that, but we should include in those studies AI. What is the help of AI? Otherwise, they will ask us, after we've done the study, hey, what about AI? So, the entire diagnostic pathway and screening will need to benefit from AI. Otherwise, we cannot maintain it. And it will definitely need it, improve it. So, be in control, otherwise the AI ape is on the loose. I hope this works. So, let's see what happens if we give AI the free hand. The AI ape. This is new. Hey, good positive predictive value. Hey, here you are. Hey, here you have a patient. Okay. Yeah. AI is taking over. Thank you for your attention.